Okay, good afternoon, everyone who's joining us today. We have had great response to our outreach on this afternoon's topic, which is celiac disease and related conditions. So we anticipate a lively and informative discussion. Our expert today is Dr. Stefano Guandolini. He is a very popular presenter at our town halls, so we're very excited to have him back. I think part of his popularity stems from the fact that he is very plain-spoken and is really quite skilled at explaining things in a way that patients can understand and can relate to, and plus he just has a nice way about him. So welcome, Dr. Guandolini. A little bit about him. Dr. Guandolini is an internationally recognized expert in celiac disease, as most of us know. He's professor emeritus of University of Chicago and the founder of the Celiac Disease Center there. Dr. Guandolini's clinical and research efforts have greatly influenced the way celiac disease is diagnosed and treated today. And for that, all of us who either have celiac disease or have a family member or friend are quite grateful. In fact, his work contributed to the revision of the 20-year-old guidelines for celiac disease diagnosis. Dr. Guandolini has been ranked among America's best doctors since 2008, and you'll very quickly see why. If his bedside manner translates very well on these town halls. In 2012, he received the prestigious title of Master of Pediatrics from the Italian Society of Pediatrics. And just this year, he published the revised textbook of Pediatric Gastroenterology, Hepatology, and Nutrition. And so I'm pleased and excited to welcome Dr. Guandolini, and perhaps he has a few words to share himself.
Thank you very much, Amy. I appreciate your kind introduction. It's flattering introduction. But now, just to break the ice, I was remembering as you were speaking about the way we worked at improving and changing the diagnostic practices for celiac disease, that this condition now is worldwide known to be quite prevalent, and the awareness has really risen to very high levels recently, fortunately. But when I began many years ago, more than I care to remember, I should say, celiac disease was considered a rather rare entity. And in fact, I remember vividly some colleagues telling, why are you wasting your time with this? You probably never encounter more than 1 or 2 patients a year. Well, those times are gone. Now we have found that this is actually a very common condition, a very common autoimmune disorder. And I'm glad that not just myself, but many other incredibly expert colleagues dug into this area and brought to fruition a lot of new information. So here I am. I'm excited at this round 2 of my appearances for Beyond Celiac, and I'm aware, and ready to tackle the questions. I hope they are not nasty questions.
No, we have a great group of a patient community that really is very excited to learn everything that they can. And this for them is a great opportunity to have access to someone with your knowledge and expertise. I neglected to introduce myself and my colleagues who are helping today. I'm Amy Ratner. I'm the Director of Scientific Affairs for Beyond Celiac. Erin Miller and Bailey Armon are going to be come familiar to you because they'll be working in the chat, and they will help out with live audience questions as we go forward. So you'll see their names, and that's who those are. So Dr. Guandolini, in addition to that long list of acclaim that I started the webinar with, he's also a medical advisor for I'm Aware. I'm Aware is also the sponsor of this town hall, and for that, Beyond Celiac is grateful. I'm Aware provides at-home testing for a variety of medical conditions, including celiac disease monitoring and screening tests. And also, we have something to share with you that's pretty interesting and exciting. From now until July 31st, you can save 15% on all of I'm Aware's tests when you use the code Beyond Celiac, all caps, 15. And I'm sure they'll put that in the chat so you don't have to rely on my description. The website and the code, of course, will be posted in the chat. So I know that you're all here not to hear me, not to see me, but to have Dr. Guandolini answer some of the questions that were submitted in advance. We collected these questions at sign up. And so we tried to order them in a way that will respond to the wide variety of things that people were asking us. So if you're ready to go, Dr. Guandolini, here's the first pitch, shall we say. Okay. What are the most common comorbidities associated with celiac disease?
So the first thing I want to say here is that celiac disease being so common, as we just mentioned, like 1% in general of the general population, clearly many conditions just happen to be present together with celiac disease, just as it would with any person that does not have celiac disease. And the list of conditions that have been described associated with celiac is actually quite long. But again, one must be critical and distinguishing what are true associations, meaning diseases that occur definitely much more frequently in people that have celiac disease compared to the general population, and differentiate these by conditions that occur equally commonly in both conditions, in control and in celiac patients. So that said, as I said, there is a long list. The best known associations are with autoimmune conditions, reason being that celiac disease is an autoimmune disease, and it shares a number of common genes with other autoimmune conditions such as type 1 diabetes. Thyroid diseases are the most common and prevalent associations. And then there are chromosomal disorders such as Down syndrome. Patients with Down syndrome, the prevalence of celiac disease is around 10% in them. Other chromosomal disorders, Turner syndrome and Williams syndrome, which is kind of rare. And then there are a number of conditions that are neither autoimmune nor chromosomal that seem to be associated more with celiac disease. A few years ago, we did an investigation to estimate the cost associated with celiac disease comorbidities on a large number. It was an investigation on a database of more than 12,000 patients and 12,000 matched controls. And we found out that there is a long list of comorbidities. Among them, cardiovascular conditions, coronary heart disease, myocardial infarction, also cerebrovascular diseases, and then rheumatoid arthritis, joint musculoskeletal conditions in general. And then again, the list goes on and on. To make a comprehensive list would require more time, but there are at least about 20 associated conditions. Again, the most common of them remain autoimmune disorders, though, for sure.
And is there a level of concern that people with celiac disease, diagnosed with celiac disease, should have about these? Because can you put it into perspective how much concern they should have about these associated conditions? Sure.
So just to give you an example, when I refer to cardiovascular diseases, myocardial infarction, congestive heart failure, and peripheral vascular disease, they occur between 1.5 and 3 times more commonly in patients that have celiac disease compared to the general population. Liver disease are more frequent. Peptic ulcer disease, we are talking about 3 to 4 times more frequently. Also renal disease, and as many celiac patients know, also the risk of lymphomas, leukemia, appears to be twice as common, more or less twice as common in patients with celiac disease. Now, the one thing that needs to be said, though, is that even though the risk is more frequent in terms of absolute numbers, we are not talking about, this is not a pandemic of this condition for celiac patients. We are talking a risk that goes, instead of having, let's say, 500 patients affected by malignancies in 15,000 individuals, we have 700. So yes, it's more. Clearly, it's almost double, but still the absolute numbers remain relatively low. The other thing that has to be said is that for some of these conditions, osteoporosis, for instance, adherence to the gluten-free diet, strict adherence and full remission of the inflammation linked to celiac disease appears to be very beneficial in kind of pulling the brakes. So the prevalence of these conditions become less high in patients who are on a stable and well-controlled gluten-free diet. So that's the good news, basically.
Right. And I'm sure that's helpful for people to know, because sometimes you don't know how much you should be worried about some of the numbers that you hear. So the second question that we had submitted to us in advance was, can you explain the relationship between autoimmune arthritis and other autoimmune diseases and celiac disease? I guess the bottom line here is, why are they connected?
Yeah, well, we know only in part the answer. There are new data that seem to relate both autoimmune conditions and celiac disease to a combination of genetic and environmental factors. The genetic factors are quite well known. They have to do with some associations with genes belonging to a class we call HLA. As you probably, most of you know, celiac disease occurs only in individuals who have HLA DQ2 or DQ8. Well, these genes are part of an assay or group of genes called DR3, DR4, which are also present in autoimmune conditions. So you have to have some genes that give you the predisposition. And then among the environmental factors, the most recent and culprit appears to be viral infections. Viral infections of the first year of life in particular have definitely play a role in the onset of celiac disease, and possibly there is some evidence also in type 1 diabetes and maybe other autoimmune conditions. So those could be the common links. We also come to learn that there are some additional risk factors for celiac patients to develop associated autoimmune conditions. One of them is being female. Being female increases the risk. Having a family history of autoimmune conditions. Having also positive anti-gliadin IgG. So the celiac serology is, of course, is a constellation of different tests. And these tests, the anti-gliadin IgG, don't have a specific great role in diagnosis. However, if you have them, it seems that your risk of developing autoimmune conditions it's higher. Also having vitamin D deficiency. Vitamin D deficiency plays clearly a role. So when you put together all these risk factors, you can have an idea of why some people are more affected than others. Maybe they have the right genes, maybe they have had the viral infections in the early stages of their life, maybe they are female, maybe they have a family history of autoimmune conditions and so forth.
So it seems like a combination of factors are at work for people to review it within their own particular story. How can this is a question that comes from someone who has either getting a little older or thinking about what it will be like to get older. But what they would like to know is, how do you differentiate between the gradual physical changes of aging from possible celiac disease comorbidities?
That's a difficult question, because some of this, I mean, if you have, if you develop, for instance, arthritis, and arthritis, of course, is known to be part of aging. It's almost it's affecting a large proportion of individuals above the age of 60, 65, and so forth. So is my joint pain related to just aging, or is it due to something else? Or is it due to celiac disease? I would say one of the first steps could be, first of all, you can run some of the tests that are available, including those that IMEWare produces, like the heart health test, or the thyroid test, etc., to suspect specifically some problem there, and then discuss the results with your healthcare provider. So I think it boils down to having a healthcare provider that you trust, that is familiar with celiac disease, that will be able, of course, to investigate adequately whether your symptoms or whatever is causing you some trouble is actually could be associated with celiac disease or not. And then again, there are tests that can help to differentiate that. one of the tests is also the celiac serology, because if the serology remains normal, it's not 100% correlation, but it's a good support to the fact that probably what's going on is not related to celiac.
Mm-hmm. Okay, I'm sure that that's very helpful for this person and anyone else who has that concern who's tuning in. Can the inflammation caused by celiac disease set someone up for greater cardiac disease risks?
Yeah, as I was mentioning earlier when I quoted the study we did a few years ago, we did find a much higher prevalence of cardiovascular disease in patients with celiac disease. We don't know exactly what are the factors, but it's likely that the systemic inflammation that is part of celiac disease contributes to creating this problem. Here is the place where tests like the HS-PCR, so high-sensitive C-reactive protein, can be helpful in detecting earlier if there is an inflammation that goes beyond what is expected in celiac disease, and perhaps lead to the changes that are found in cardiovascular disease. But the answer is yes. Unfortunately, the systemic inflammation found in CD is one of the factors that leads to the increased prevalence of cardiovascular diseases.
Thank you. So this question has to do with the gluten-free diet, which of course we know currently is the only treatment that we have for celiac disease. Can a gluten-free diet help those with autoimmune diseases other than celiac disease? For example, Sjogren's, RA, or lupus?
So this would be a very interesting fact if this were the case. And the fact that there have been studies trying to address this in a retrospective or either prospective also manners, and the evidence is actually quite weak. So in other words, I think we don't have enough evidence to suggest that the gluten-free diet might be helpful in patients to prevent to improve the situation, the clinical status of patients that have rheumatoid arthritis or Sjogren or psoriasis or type 1 diabetes. This is unfortunately, there is no evidence there. Now, lack of evidence does not mean evidence of lack. So it may be that further studies, maybe better conducted studies, might shed new light. But as we presently know, there is no evidence that the gluten-free diet helps in other autoimmune conditions besides celiac disease.
Mm-hmm. Yeah, and I think
of course the non-celiac gluten sensitivity, but that's an entirely different area, obviously.
Right. And I think it is helpful for people to know that in light of a climate where the gluten-free diet can be proposed as a bit of a cure-all for a lot of things, and it gets confusing. For someone with celiac disease, they have no choice, but in the broader world, there's a lot of information out there that can really confuse you as to, is it a healthy diet? Is the diet I should try other than for celiac disease? But it seems like what you're saying is that it's for celiac disease, yes, for other conditions, not so much.
No, yes, thank you for the opportunity of expanding on this problem, because this is also, it's a recurring question. Gluten-free diet is not a healthier diet. It just is not. Especially if you rely on a gluten-free diet mostly with foods that are manufactured to be gluten-free, because in that case, literature has shown many times around from Europe and from the US and from Canada, has shown that the majority, I would say, of foods that are manufactured to be gluten-free end up by having no fortifications or lower fortifications in vitamins, have lower amounts of fiber, tend to have more caloric content, more fat. So they clearly do not offer any benefit on a gluten-containing normal, so to speak, diet. And I would not recommend anyone who does not have the need as celiac patients to be on this diet, to embark on one. Now, that said, to be fully honest, you know, if one intends by gluten-free diet, a diet based on the millions of products that are there between the animal and the vegetable world, you know, fish, all sorts of poultry, or different cereals, of course, you have tapioca, you have quinoa, you have rice, you have corn, and then all fruits and vegetables. If you rely on a diet of that sort without going to the grocery and spending money on gluten-free food, then there is no reason that this diet is less healthy than the normal diet. One more point, if I may, on this, on the diet issue. There have been studies showing that the use of Mediterranean diet for people that have celiac disease, of course, gluten-free, Mediterranean diet, large amount of fish, olive oil, we know what you're talking about, is actually beneficial. It has an anti-inflammatory effect, possibly mediated through a beneficial effect on the microbiota, and it has been shown to be helpful. In addition, studies have shown that the use of Mediterranean diet in babies that are born at risk for celiac disease, being the offspring of one or both parents that have celiac disease, for instance, helps preventing or reducing the risks of developing celiac disease in the children as they grow. So I just thought, as somebody who is Italian, I thought I would use this this tool to promote the use of Mediterranean diet, which really seems to be very very healthy from all cardiac.
Yeah, it does come from your native part of the world, so
yeah, exactly.
Totally to be understood. I think, you know, there are those of us in celiac disease who have heard stories about the first suggestion of celiac disease coming from a dentist, which sounds kind of unusual. And so the question that was submitted to us was, does celiac disease affect your teeth?
It does. The most common problem is dental enamel hypoplasia, which is basically a damage, a reduction of the enamel on the teeth. Enamel, of course, has a very important function, not just aesthetic, but also to protect the tooth. The prevalence of enamel hypoplasia in celiac patients has been variously estimated between 10 and 90%, so appears to be really very common. And as you were saying, it is probably due to nutritional deficiencies and immune disorders that can take place during the time where the enamel is formed, especially during the first 6 to 7 years of life. So affects also the permanent dentition much more than the deciduous one. And once it's there, it's irreversible, of course. And as you were saying, because it can happen in the complete absence of any other gastrointestinal or extraintestinal manifestations of celiac disease, it may be a red flag. So if somebody is found, or if you have a child that has this problem, whether or not there are other reasons to suspect celiac disease, a test, a screening for celiac definitely has to be done.
I think I think it must have been a dentist, actually, I'm not sure, once said to me, the way to think of the digestive system is that it begins in the mouth. So I always thought that was an interesting way to look at the digestive system. So
absolutely. There are also other defects of the enamel, but also affecting the enamel pitting or partial or complete loss of the enamel. So that's basically. And there are also other issues affecting, since we're talking about the mouth, affecting the mouth, like geographic tongue, or little pieces of discoloration on the surface of the tongue. And then aphthous ulcers that are also not typical of celiac disease, because they can be found in inflammatory bowel disease, or sometimes are idiopathic. We don't know why they occur, but those painful mouth ulcers, they can also be commonly found in celiac disease. And if somebody has this, by all means, they should be investigated.
So this is a broad question, and so it may take a little time to answer, but one of our people in our community wants to know, does celiac disease affect fertility?
Fertility. This is still being debated. So the original studies that were done actually in Italy, talking about 30 years ago now, they actually seem to have proven that the prevalence of adverse effects on pregnancy was higher in celiac patients than in celiac women than in control. However, subsequent studies have failed to replicate that. So I think the jury is still out. There is some hint that indeed this could be the case. Now, bear in mind, we are talking about untreated celiac disease. I want to be extremely clear on this point. There is abundant evidence that if a woman is on a with celiac disease is on a gluten-free diet and maintains the diet, there has been no report of adverse effect on pregnancy, no stillborn, no other, premature birth or low birth babies, etc. So these are all risks that are reported and begin with conflicting reports, but mostly, if not exclusively, on women that were not diagnosed during pregnancy.
Is there cause, I'll just use that word, is there cause then for a woman who's having difficulty with fertility and who might also have some other kinds of symptoms for the, what would it be? I guess it would be your gynecologist or your obstetrician to test for celiac disease. Would that be a normal thing to do or something that's commonly done, or is it virtually overlooked, or where do we stand on that?
That's a very good question. I would agree with you. So I would think that if a woman has issues with getting pregnant and other more common causes have been ruled out by the gynecologist, yes, they should be tested for celiac disease, because you may have a lower fertility rate if rampant celiac disease is occurring because of the inflammation, because of the nutritional issues, a number of issues. And there are many stories, including some that I've seen personally in some of the co-workers of mine at the University of Chicago, that that I can testify for, that they didn't know they were celiac, they could not get pregnant, then the diagnosis was made, the treatment began, and then all of a sudden pregnancy started. So yes, they need to be tested for celiac disease, absolutely. And this is an often overlooked cause. So.
Right. I would agree that is the case. So moving along, do you think should all those who have type 1 diabetes be tested for celiac and vice versa?
Most definitely so. Even though most commonly it's diabetes that comes to be diagnosed first, but also somebody that has celiac can then be diagnosed with type 1 diabetes. The most common story is you get tested, you are symptomatic for diabetes, you get diagnosed with diabetes, and then yes, 100% you need to be tested. All the major societies that work in this area, not just the GI societies, but also the endocrinological societies that are involved in providing guidelines for patients diagnosed or suspected to be diagnosed with type 1 diabetes, do recommend being tested at the time of diagnosis for celiac disease. The prevalence of unknown celiac disease at the time of diagnosis of diabetes is around 10%. So it's really very high. It's like 10% more common than 10 times rather more common than the general population. But I want to add another problem, which two issues. One, you may have no other symptom. So somebody who has type 1 diabetes does not have to wait until or unless they develop, say, diarrhea or weight loss, then they get tested for celiac. They may have no symptoms. And actually, the most common form of celiac disease in patients who have type 1 diabetes, when it is first diagnosed, is they have no symptoms or really minor symptoms, not enough to seek medical advice. So everybody should be tested. The second thing that I want to be sure to mention is that, unfortunately, if you tested negative at the time of type 1 diabetes, if tested negative for celiac, that doesn't prevent you from developing celiac disease later on. So if you keep eating gluten, which is okay, if you don't have celiac disease, why should you go on a gluten-free diet? Well, then your possibility of developing celiac disease is still there. So you have to be retested. Now, how often depends, of course, on each individual case, but in general, it is recommended at least every couple of years to be retested. And most endocrinologists would actually, at the time in which they do a checkup for diabetes, they would run the TTG test. It's a simple blood test, a tissue transglutaminase antibodies, which is very sensitive. And if you do so, then you certainly are able to pick up pretty early new celiac disease, because studies have shown that up to even 40 years after the original diagnosis of diabetes, you may develop celiac disease. That's unfortunately the name of the game. Now, of course, going gluten-free would prevent that. But, you know, there is no one that would recommend putting on gluten-free 100 diabetics just to protect 10, basically. That's the long and the short.
Mm-hmm. Would undiagnosed celiac disease play havoc with your type 1 diabetes? In other words, you have undiagnosed celiac disease. Does it have an effect on how well you seem to be doing on the diet that you have to follow or the insulin that you're taking for type 1 diabetes?
Another interesting question. There are actually, incredibly enough, the more we know, the less we know. In other words, there have been studies. Initially, there seems to be a lot of enthusiasm. Yes, the gluten-free diet really helps controlling diabetes. They feel better, the absorption is better. They don't need that much insulin. On the other hand, then there were studies showing quite the opposite. Actually, they absorb more, so the glucose tends to be higher, so the diabetes is more poorly controlled if you actually start the gluten-free diet being celiac and diabetic. And then there have been the majority, however, and the most recent studies on large numbers seem to show that basically there is no quantifiable effect, neither positive nor negative, of the gluten-free diet in controlling diabetes. But, you know, this is more, to me, is more a rhetorical question, because, you know, maybe I'm old-fashioned and, you know, probably my age has a part in this, but I am of the old school of thinking that if you have a disease and there is a treatment, you do treat your disease. So if you have celiac disease and diabetes, but you have celiac disease, you need to go gluten-free diet. Whether or not this helps with diabetes, it's almost irrelevant. You can hope it does help, and in some cases, perhaps it does. But even if it doesn't, you must treat your celiac disease. You can't just ignore it. Even if you have no celiac disease, that's another point connected. Celiac disease patients, whether or not they have symptoms, and regardless of the symptoms they have, if they keep eating gluten, they are at risk of complications, much more, especially anemia, especially osteoporosis, but other risks, including malignancies, if they continue to eat gluten, whether or not they have symptoms. So that's the important thing. You don't have to base your diet on whether or not you have symptoms. You need to protect yourself by being gluten-free. And again, you said before, currently is the only treatment available. I got that, and that is a very interesting adverb, because there is so much research going on in finding a cure for celiac disease that I'm pretty optimistic that the gluten-free diet, at least the very strict gluten-free diet for life, won't be the only option for celiac patients within a matter of years, possibly a few years. But we are not there.
Right, that would be good news, I think, for all of us. Can you explain the relationship between celiac disease, anxiety, depression, and mental health?
I wish I could. No, I don't think anybody really knows exactly. So there are a million of hypotheses. But one thing is for sure. Once again, unfortunately, the prevalence of especially anxiety and depression, all sorts of psychotic actually disturbances in patients with celiac disease is higher. Again, we are talking about twice as high, so it's not like every celiac has this, but it's higher in patients with celiac disease, especially undiagnosed, but also, unfortunately, in diagnosed. And the reasons can be many. In patients who are, actually, there is a study showing that patients on gluten-free diet, celiac patients on gluten-free diet, appear to have even a higher prevalence of anxiety and depression compared to celiac patients who refuse to follow the diet. which is interesting and counterintuitive. One of the reasons could be that they feel the social burden of being gluten-free. You know, the isolation. We all went through the COVID pandemic and the isolation and the lockdown and so forth. So, and that has in fact increased enormously the referrals for depression and anxiety. I'm talking about outside of celiac disease. So you can imagine that the sense of isolation, of being different, of not having the chances of enjoying a pizza with friends, etc., especially for teenagers and adolescents, can be pretty demanding. So that may be a contribution in somebody who has some predisposition. But going back to the root of your question, can I explain why there is this association of what causes this? I don't think we have all the elements yet to say that. One of the possibility, I don't want to appear fixated on this issue, but it could be lying in the microbiota. Microbiota, there is a gut-brain, there is a microbiota gut-brain axis. This is now well known and has been explored extensively in recent years. And one of the effects, positive effects of a healthy microbiota is actually to maintain a situation of, if you wish, good mood, so to help relieve stress and anxiety. And vice versa, if you have the condition of dysbiosis, which appears to accompany celiac disease, then you are more likely to develop psychiatric issues, including anxiety and depression. But this is, again, it's a speculation, just because the question was if I can explain the connection. I can offer hypotheses.
I know there is a lot more discussion now about the gut-brain axis, and I think a lot more harder looks at what that means for people in general and people with celiac disease overall. So the next question is about the anti-nuclear antibody, the ANA test. And this is the question. It says the ANA test is a common initial blood test to provide evidence of certain autoimmune conditions. However, notably, false positive ANAs can occur in up to 13% of healthy individuals. Somebody knows their stuff here. There is a recent literature examining the prevalence of a positive ANA test in people with celiac disease. And so here's the question. Is there a biologic mechanism whereby a positive ANA is connected to celiac disease in and of itself? Or in a celiac disease patient, does a positive ANA often suggest a comorbid autoimmune condition?
This question must be formulated by some of my colleagues because it's too medically phrased.
Yes, it's quite
it goes
precise.
Beyond my capacity of no, I'm joking. So now the ANA, the anti-nuclear antibody test, is utilized as one of the screening tests for rheumatoid arthritis, for conditions that are autoimmune but related to rheumatic diseases, basically joint issues, arthritis, etc. The problem with it, as the question said, is that it is often positive in individuals that have no issues. So I think it's one of those tests that have low value if at normal levels. Now it's different, however, it depends on the positivity. A test that is positive at a rate higher than 1 to 80, I think that's the threshold. If it is positive but less than 1 to 80, I would just ignore it. I don't think we can give it any meaning. But a test which is like, say, 160, 320 or more, which is the case when you have an arthritis, rheumatoid arthritis, or a condition that is associated with this increase, you have very high titers, then that is meaningful. Now, the link of ANA with celiac, I am not aware of any specific link. I don't think this test can be used to diagnose or to rule out celiac disease at all. I'm not aware of any association. Now, that said, children also that have a new diagnosis of celiac disease, if studied with new technologies like ultrasonogram of the joints, may show that there are signs of joint inflammation in a large number of them. And this goes down to almost zero after a few months of gluten-free diet. So there is clearly and active inflammation of the joints, which might produce some low titers of ANA, but I don't think we need to give too much value to that.
Okay, now we know all about ANA, right? So we have a wealth of other questions that were submitted in advance, but I think we're going to give our live audience a chance to ask some questions. And this is one of them that came up in the chat, and that is there any correlation between dementia and untreated celiac disease?
Yeah, let me try to retrieve real quick, because I think I had, I want to give a number rather than just my thought. Yes, again, I'm referring to a paper, a study we did, a paper we published in 2016, I believe, on this large number of subjects. And the prevalence of dementia, I'm reading from our paper, was 0.4% in the control population, or again, more than 12,000 individuals, and it was 1.7, so 4 times as much in patients with celiac disease. I cannot explain the reason. Remember, also I'm a pediatric GI, so my orientation, my focus is mostly, and experience is mostly on children, even though I know one thing or two on celiac disease in general. But dementia, the reason for the dementia are not clear. Alzheimer's is a specific disease where there are fibrils of amyloid produced by neurons that accumulate in the brain, and we don't even know the reason for that. So celiac disease is not characterized by production of amyloid, so I don't think there is any explanation for the reasons. But yes, as I just mentioned, we did find a higher prevalence of dementia in patients with celiac disease.
Okay, thank you. And you may have touched on this a bit, but there still seems to be a little bit of uncertainty in our population, and my question just went away. So the question coming again from our audience is, if I'm a parent with celiac disease myself, should I automatically have my child tested?
Yes, because the prevalence of celiac disease in children born to families at risk, and again, by families at risk, I mean when there is at least one parent or a sibling affected by celiac disease. Now the prevalence is around 10 to 20%, depending on the series you read, and it is higher in females than in males. That is in general the prevalence of celiac disease. So yes, the one thing that you could do is at birth, utilizing the umbilical cord blood, which is the baby's, you can test for the HLA status, because that's an easy test. And if the baby does not carry either DQ2 or DQ8, then this individual does not need to be tested for celiac disease for the rest of his or her life. If that is not done, it can be done, of course, later in life. If the baby has to be handled, so to speak, normally in terms of timing of introduction of gluten, amounts of gluten probably need to be kept on the low side for the first couple of years of life. Again, I want to mention here the role of Mediterranean diet in these children during the first couple of years of life. And the test for celiac disease, if the child grows normally and there is no reason for concern from a clinical standpoint, the first time that I would recommend testing the child is when they turn 2. Before that age, it's not going to be informative, and you don't even have given the immune system the time to react. So it is a nonsense. Of course, some children may develop celiac disease very early on. I remember the youngest child ever diagnosed was a 4-month-old baby, because it was given gluten during the second month of life. Families at risk. I'm talking about decades ago, but some of the things that stick in your mind. And a positive diagnosis of celiac disease was done a little more than 4 months. So you can develop at any age, but in general, it takes a few months on gluten to develop celiac disease. So I would not recommend testing before the age of 2. Once again, if there are no symptoms, because if you are dealing with a baby who is not growing, who has diarrhea all the time, a large abdomen, or throws up, and belongs to a family at risk, by all means, they have to be tested. And once the test, just to conclude, once you test the baby, the child now at the age of 2 and is negative, unless there are new symptoms, you can test it like every other year, something like that. Doesn't have to be an obsession to be done every year. Again, if symptoms appear, then it's different.
Right. So it's interesting. What you're saying sort of correlates with my own family story, where my daughter was approximately 2 years old when she developed very noticeable symptoms and then was subsequently diagnosed. So in our audience, we have a number of people who are asking, and again, Aaron and Bailey are monitoring these questions, but a number of people have been asking about a connection between colitis and celiac disease. I would assume that also includes microscopic colitis. Not too familiar with colitis, but that's the question. Is there a connection between colitis and celiac disease?
So yes, there is a, first of all, let's define colitis. As you said, it can mean a number of different things, because colitis could be infectious. If you have a Shigella or a Salmonella infection, like we used to see a lot of in the old days in Naples, Italy, then of course you have colitis, but that has nothing to do with celiac disease. But I guess the question refers to either ulcerative colitis or to microscopic, as you were saying, microscopic colitis. So ulcerative colitis is part of the inflammatory bowel disease, and it is a condition that has an autoimmune component. So there is, yes, there is an increased risk of association between ulcerative colitis and celiac disease, although not very high, but there is a slightly higher prevalence of one condition when you have the other. Then it's different for microscopic or lymphocytic colitis, which is a diagnosis in which the colonoscopy will not disclose any ulcers. There is no bleeding, but there is a microscopic inflammation that leads to watery diarrhea and to symptoms. Now, lymphocytic colitis, or also part of the microscopic colitis, that is actually known to be strongly associated with celiac disease. And it does respond, at least in part, it does respond initially to a gluten-free diet. In most cases, you need to add also a specific treatment for colitis, such as a steroid or other preparations nowadays that are available. But yes, microscopic colitis is more frequently associated, and also is also colitis to a lesser degree.
Okay, thank you. Someone else would like to know whether there's a correlation between celiac disease and SIBO. Is SIBO curable with underlying celiac disease?
So SIBO, small intestinal bacterial overgrowth, is that the question, right? SIBO.
Yes.
Yeah. Let me think before I answer one way or another. So theoretically, there should be no reason for these associations, because you know, SIBO can occur in a number of circumstances. It's usually the result of a surgically created problem or a very sluggish motility. Now, you may have decreased intestinal motility in celiac patients, which is one of the reasons some celiac patients develop constipation rather than diarrhea. But I don't think there is a higher prevalence of, I may be wrong, but I don't remember having seen or having read that SIBO is more frequent in patients with celiac disease. That said, the symptoms may overlap. So if the question is, should a celiac patient that has symptoms, in spite of being gluten-free diet, investigated for SIBO, the answer is definitely yes. Nowadays, we have means to diagnose as well as treat small intestinal bacterial overgrowth. So yes, for instance, even irritable bowel syndrome is found more commonly in patients that have celiac disease. It's a different condition, but I mean, the associations, as I said, originally are many. The one with SIBO, I'm not specifically aware of, though.
Mm-hmm. I would think it's hard to tease out. So you said irritable bowel syndrome from celiac disease, that it would be hard to determine whether it was all celiac disease or some combination of the two. Is there a way that can be determined?
Well, yes, clinically, you know, again, maybe a little bit of old-fashioned way of thinking, but clinically, if you have celiac disease, which is rampant without being diagnosed, before being diagnosed, you do have in addition to the diarrhea, the abdominal pain, and the bloating that are characteristic also of irritable bowel syndrome, you do have weight loss or inability to gain weight. So you have signs of nutritional deficiencies, which by definition are not part of irritable bowel syndrome, where the absorption is basically normal and you don't have any nutritional deficiency. And then, of course, the tests we will tell you, there is no specific test for IBS, although there are new ways that people suggested that might be beneficial in terms of testing. But in reality, the test for celiac disease is available and is very, very helpful. Again, checking the levels of tissue transglutaminase. And you can do this at home once again, just to go back to Imaware, and then discuss the result with your physician. But if you have high levels of TTG, this specific antibody, tissue transglutaminase antibodies for celiac disease, this is a highly sensitive and specific test for celiac disease. So once you have that kind of result, you have to run to your doctor to get the diagnosis finalized. Now, this may require a biopsy. In most cases, it does. In children, if you have a second test, which is positive, and you also associated with the highly specific test called anti-endomysium antibody, or EMA, then new guidelines, now since several years, reiterated in 2020, they allow the physician to make the diagnosis without the biopsy. So that's good to know. So you have to go to a specific, I'm talking about pediatric age. This is being now debated and discussed, and I know that there will be a specific roundtable in the next World Congress on Celiac Disease, which will occur in Sorrento, Italy, in October, because this is very much a hot topic within the adult world of celiac experts. Can we also diagnose celiac disease without the need for a biopsy? But right now, they have to do a biopsy. So going back to the question, yes, you can try from a clinical standpoint to gauge whether or not the patient has IBS or celiac due to the presence or absence of nutritional deficiencies. And you have this extremely sensitive and specific test to make a good screening for celiac. And if negative, then you go toward IBS.
Mm-hmm. So I could almost envision a scenario where if you have been told you had IBS, but it doesn't seem to be, if you want to know more about that situation, then testing for celiac disease via your physician or I'm aware or whatever could be a way that you can get answers for yourself as well. On that particular question. Also, since you mentioned the International Celiac Disease Conference, which is coming up in the fall, which is barreling toward us very quickly, I just want to note to our audience that Beyond Celiac has several studies that they're presenting there in the form of a poster based on our Beyond Celiac patient registry. And if you have not registered for that, it would be a good idea. And also results from a study that we're doing on a topic that was discussed today, or not that we're doing, but that we're funding, related to the gut-brain axis through researchers at Sheffield University, will also be presented at that very important celiac disease meeting, which is held every 2 years. So this question has a little bit of resonance with me because it does reflect sort of my story, my family story. But this is the question from one of our listeners or our viewers, I guess I would say. None of my family members has celiac disease, and I had never heard of it before my daughter was diagnosed with this. How does this even exist without a family history? How could this have happened?
Well, first of all, I would challenge the absence of family history. Celiac disease can be very protein. So you may have had some of the relatives that had celiac and went through life without being diagnosed because they had maybe minimal symptoms. They were lucky enough not to have it, and they were not tested. So the fact that there is no known celiac patient doesn't rule out completely the presence of celiac disease. That said, many times you have a new patient that is diagnosed in situations in which there is no family history. You don't have to have a family history of celiac disease to be diagnosed. You could be absolutely first generation. That is well known, and that happens all the time. So.
Okay, that clears it up a little bit.
Will you be in Sorrento as well for the celiac ICDS?
No, actually, I'm not going to Sorrento, but Alice will be there. So
okay.
We'll be well represented. So someone has a question about what the percentage is of people with celiac disease on a strict gluten-free diet who develop stomach or intestinal cancers.
So it seems that if you are diagnosed with celiac disease and are on a gluten-free diet, the crucial period is the first 2 to 3 years. In other words, if you do not develop cancer, lymphoma, the cancers associated with celiac, during the first couple of years after the diagnosis, being on gluten-free diet, then you're off the hook. Then your prevalence is exactly the same risk as the general population, which is great news, I think. Now, patients who are not following the diet is different. There was an old study published in The Lancet, I think in 2000, 2001, something like that. Again, showing very clearly that the degree of adherence to the diet was directly associated with the mortality over the following 5 years. So the more you are adherent and following the diet, the less likely you have to have complications, including cancer. So the prevalence was basically back to normal within a few years. It's higher during the first 2 years because, of course, you have the whole past history of eating gluten most of your life.
Okay. Yeah, I think that always is encouraging, particularly to someone who's been diagnosed for a while and has gotten past that early threshold of where there's the most concern. So someone had asked whether there's a connection between celiac disease and lactose intolerance.
Yes, there is a connection. Celiac disease affects, as we all know, the small intestine, causing the villi, this finger-like rejection, to become blunted. So because we digest lactose due to an enzyme called lactase, which is basically anchored on the top of the villi, when you lose the villi, then you lose lactase. So the lactose, which is a disaccharide, so it's a sugar composed by glucose and galactose in one. If you digest lactose, then the two monosaccharide, the single sugars, get absorbed easily. But if you can't digest lactose, then this double sugar goes undigested in your intestine and causes the symptoms, which are bloating, which are diarrhea and abdominal pain. The good news is that if you begin your gluten-free diet, the normalization of the villi, I mean, hopefully in the majority of cases, does not happen always, unfortunately, but in majority of cases, takes only a few weeks. Certainly in kids, takes no more than 3-4 weeks to become back to completely normal. So your lactase is again up there, up and running, and you can digest lactose again. So eliminating lactose is recommended only if you have symptoms and only during the first couple of months on the gluten-free diet. In adults, it might take longer. In addition, because things are never so simple in life and in medicine, for sure, in addition, there is this condition called adult lactose intolerance, or the non-persistence of the gene. Many adult individuals, especially some ethnic components, tend to lose lactase spontaneously. It's a genetically pre-programmed loss of this enzyme. So it just comes out of the villi, and even if the villi are healthy, there is no more lactase in it. So then you cannot digest lactose, but this has nothing to do with celiac. Celiac plays no role in this. And this affects about 30% of the population.
Right. Yeah, I think that early lactose intolerance is something that gets talked about a lot when you're first diagnosed and you're figuring out the diet and what might be going on. Someone asked whether if you're younger when you're diagnosed and you begin a gluten-free diet, are your chances lower of developing other comorbid conditions?
That's a fantastic question, because it was exactly the question that we asked years ago in a multi-center study that we performed in Italy. And the answer is yes. We found a striking correlation between age diagnosis and prevalence of autoimmune conditions in early adulthood. So if you take a bunch of people in their late 20s, early 30s that have celiac disease, and then you divide them among those who were diagnosed during the first 3 years of life, 3 to 6, etc., different age groups, you find that the prevalence of autoimmune conditions in those that were diagnosed early on was much, much lower than the prevalence found in those who were diagnosed after age 20. So that seemed to be a very convincing study that remaining gluten-free for longer would actually prevent the onset. And we all believe in that study because it was a large number, it was very well conducted, etc. However, that said, in all truth, I must also add the subsequent studies with different methodologies, though, could not reach the same conclusions. So the evidence is there, but it's not very, very strong as I thought it was when we first published this.
Mm-hmm. Yeah, and I think that's something too that when people look at research into celiac disease, sometimes the changes that occur over time and as more and more evidence build is a little difficult to understand and follow, which is why we try to cover research all the time. So in other words, at one time, something was thought to be true, and then that doesn't mean the research starts. It keeps going on and on and on, and then it's revealed to be not as true as everyone thought. So it's always an ongoing process.
A good example for me as a pediatrician is the role of breast milk in protecting from celiac disease. We had initial data, even a meta-analysis done that clearly showed how protective breast milk was for babies from the development of celiac disease. Then larger prospective multi-center studies completely showed this not to be the case, which of course doesn't mean that you don't have to breastfeed your baby. This is by far the best possible way that Mother Nature has to offer for feeding a baby, don't get me wrong. But it just for the development of celiac disease, it offers no additional help.
It's funny that you brought that up, because that's exactly what I had in my mind as the study that
yeah, it's a classical example. Yeah.
made people go back and forth. So we're at the end of our hour, but I'd like to end on an optimistic note if we can. And so this question comes from our audience, and it just disappeared from my screen, but they want to know why it is that you're optimistic that there may be additional treatments for celiac disease. Let's just say shortly, and we'll leave that term undefined.
We only have a few seconds. Well, I am optimistic because I know many, if not most, of the players involved in this active research. I know how engaged they are, how rigorous their methodologies is, and I've been able to act as a reviewer of papers submitted for publication to scientific papers with advancement done in different areas of research, from the pill that would limit the intestinal permeability to gluten, from pills that would degrade gluten in your stomach before it gets into the intestine, to other conditions like inhibiting the action of TTG, thereby preventing the formation of the complex that trigger the immune response to gluten. All of these 3 areas, which I incredibly briefly mentioned, are yielding important preliminary and even not so much preliminary results. Some of these studies are actually on phase 3 already. So I think there are good reasons for being optimistic. And only one that was negative was the disappointment created by the therapeutic vaccine that we had placed so many hopes in. Had a good conceptual basis, but then it failed to work. So the company unplugged basically it from being funded. So, but that's the only unfortunate study. The other 3 main areas, which I briefly indicated, seems to be very promising.
And I think that's the other thing about research too, is that I'm sure you get asked, and we sometimes get asked, well, which treatment is going to be the first one? And it's very hard to know because, at one point, one study is ahead, and then the next study advances more quickly. So I think we just have to continue to support research and find out as much as we can about celiac disease.
Absolutely. And I think Beyond Celiac is doing a terrific job in that. So I really need to praise you guys for being sponsoring research. If I'm not part of the research being sponsored, but I gladly acknowledge your role in this. And good research is the key to get out of this for good, of course.
That's exactly our perspective, and we'll take that a compliment from you because it means a lot. So I just want to take a moment to thank Dr. Guandolini. I don't know when we'll next be so fortunate as to bring him back, but we have very much enjoyed his perspective, his understanding, his ability to explain things to us on the 2 town halls he's participated in so far. Maybe we'll cross our fingers there'll be another sometime in the future. And also, again, I'd like to thank I'm Aware for sponsoring this lively, varied discussion. I could barely keep up with all of the things that people were asking on the side, but you may have gotten your answer via the chat. And so with that, we can bring our discussion today to a close.